Hi, I'm Mike Miller. I'm here with Kevin Hirsch, President of SCripps Coastal Medical Group. We're going to talk about health reform and clinical transformation in medicine in the San Diego area. Kevin, thanks for being with us today.
Thanks for having me.
First of all, can you talk about the impact of health reform for the clinicians in the San Diego area and for your patients?
Well, the effects are beginning to trickle through, Mike. And what we're finding is two things. One is that the government initiatives in healthcare reform really were the tipping point for the commercial market. And what we're seeing is a much more activity, frankly, in the commercial market than we are related to Medicare and Medicaid. We have a pioneer ACO in San Diego County with SCripps Health, or Sharp Healthcare, I should say. And we have many PPO pilots that are beginning now in the community that some of the provider bases are beginning to experiment with at this point.
And those are sort of the new payment models that were prompted by the Affordable Care Act, and the private insurers are following on and expanding upon, is that correct?
Yes, and I think what we found here in San Diego is that the majority of the commercial market was influenced by the effects of the Affordable Care Act to realize that they were unable to pay anymore at this point. Purchasers, individual subscribers, and so the commercial market has responded to the government initiatives in order to make healthcare pricing much more competitive, and it is definitely now an insurer-priced market rather than the other way around for several years, where consolidation drove higher pricing in the San Diego market.
You know, California and Southern California has had a lot more of their physicians integrated into these multi-specialty groups, integrated care systems like SCripps Coastal. Has that made it easier or harder to try and adopt and work with these new payment models?
Oh, I think being integrated definitely helps to manage that, because when physicians and the entire care system is aligned, you can create a singular strategy and you don't have the outlier phenomena that you have typically with a lot of independent practitioners and folks who are really not able to get into a systemized approach to care. We have many systems. The majority of healthcare, in fact, in San Diego is organized in one fashion or another. So I think it sets up the community for more and more participation in healthcare reform-related innovative payment models.
And the extent of capitation that already existed here didn't prevent people from looking at those other models as well?
No, it's complicated because, as you know, California, particularly Southern California, adopted and maintained capitation a lot longer than the rest of the country did. But even here in San Diego, some of the commercial HMO adoption of capitation went away in the last several years. So now there's a swing back to it. SCripps was one of those that got away from that. Because that's combined with more aggressive pricing in the marketplace now, it's intimidating for a lot of the healthcare systems. But I think the history of capitation sets this market up for more willingness to adopt population-based strategies and innovative strategies that focus on value and as well as the customer experience. I think that's going to be the magic that we're going to have to figure out how to deal with.
Yeah, you mentioned the quality issues. You know, quality's been a hot topic in health policy discussions for decades, but now it's coming into the popular discussions. You see it in the media, and the challenges are how to measure quality and then how to report it to the public so they can use it, both the individual patients, but also payers, whether it's an insurance company or a big self-insured employer. What are your perspectives on measuring quality of physicians and hospitals and then reporting that quality out to the public?
I support the notion of transparent information for the public, for our providers, and we have a culture of that within our group. The science and the culture of reporting quality is relatively new, as you know. And so getting general agreement on what meaningful quality metrics are is a bit of a challenge, particularly on the inside for physicians. Examples of difficult reporting challenges are patient satisfaction, as you know. We have physicians who don't believe in the validity of that, or who feel that there is an inherent conflict in reporting that, in emergency and in urgent care environments as an example of that. But I think in general that's a battle that we're trying to win. When I first started in practice, having a consumer-focused approach was really taboo, that patients were patients and not customers. And we really have to recognize that they are customers, and part of the magic of delivering great health care is satisfying them as a customer so they're likely to be compliant and work with the things that they need to do. So reporting quality, focusing on quality, I think is really a critical task in solving the cost of healthcare, bending the curve, so to speak.
Right.
But I think we've got a ways to go. I guess the other thing I would say related to that is that healthcare informatics are key on that, and having a singular nomenclature for all of this is a big deal, and we've got a ways to go nationally, no less regionally in that. But that's going to be a critical piece of technology that we're going to need to leverage, and then the talent behind it to be able to manage the data that we get from that.
Yeah, I've talked to a lot of people about the health IT challenges, both the actual technology of making it work, to be able to do the data collection, making sure that Jane Smith is a different Jane Smith than six others in your systems, even some that have the same birthday. How do you do the individual identifiers? And then how do you get the people to staff it? There's a real shortage of experts in that area.
Well, but when you look at some of the challenges that systems have now, even the more advanced ones, we've gone from the days of registry, where patients would be populated, let's say a group of diabetics, and put into a database, and then the day that a physician might be seeing a patient, he'd get a sort of a vomitus of 30 different patients with their metrics on there. Those are not actionable tools, and that's the challenge with healthcare IT, particularly sort of the population intelligence. What we need are point of care solutions. We need retrospective models that can stratify for disease management and high cost and catastrophic management. And then predictive modeling is very important too, so we can anticipate who will need more help and provide that help for patients. And some systems have more of that than others, but that is a mission critical technology as we move forward.
Yeah, you mentioned trying to be more customer focused in care, and the buzzword is patient-centric. And I've had this discussion with a lot of people. We don't need to get into it now, but my question I always ask semi-rhetorically is, if we're really trying to move towards patient-centric care, what have you been doing for the last 30 years if it hasn't been patient-centric? But we'll leave that for another discussion. You brought up cost as an issue too. That's obviously been a policy debate and a public debate about healthcare costs being too high going back 20, 30 years. A lot of the current proposals, shall we say, for that are, giving patients more skin in the game, bundled payments, primary care, care integration, eliminating waste, fraud, and abuse. What are your perspectives on, how best to sort of control costs, bend that so-called cost curve?
Well, I think all of those things that you mentioned are important. In San Diego, SCripps, it's really quite public knowledge, has been a relatively high-priced player in the marketplace. We're able to demand that through the last decade or so and spent all of it. So as a system, we're working very hard on diminishing variation across our very large system, which spreads the entire county here with multiple hospitals, multiple outpatient and group environments, and that variation is profound. So we have a horizontal approach to try to make the experience, whether it's ambulatory care or a cardiac bypass, that the experience will be the same from a service perspective, from a clinical outcomes perspective, and from a cost perspective. So some of the things are on the provider side to deal with that, but there's also multiple points of access that you talked about. I run a predominantly primary care group. Primary care is absolutely mission critical to the solution here. The studies are very clear about the cost and quality value of primary care and leveraging that. At the same time, it's pretty clear we have a shortage nationwide, maybe not in certain markets like mine. People still come here, but nationwide we clearly have that challenge, which leads to the issue of extenders and all of that. And I think the physician extenders are going to be a critical component of providing access to care as we go forward. But at the same time, we have to assure that the right patients get to the right place at the right time, that there's correct oversight for allied health professionals and all of that, because it's the stewardship of quality that we're going to be responsible for. And I think that is really what it comes down to in the end, is that we're going to be responsible for two things at once, which physicians are not used to, which is transactional care, dealing with the patient at a given time, and thinking about and managing the whole population that they're responsible for. And I think that's actually very exciting. That's what we really should be doing, but that's the key.
Yeah. Well, you brought up a point about, the challenges of meeting the needs of your current patients. Health reforms coming on board January next year through Medicaid expansion, which California, I believe, is doing, and the insurance exchange, insurance marketplace, which I think California is doing their own as opposed to the federal facilitated one. How, Scripps Health, the clinicians in San Diego area, being prepared for a possible large influx of newly insured patients starting next January and, in through next year?
Well, we at Coastal are sort of taking a watch and see approach right now. You're correct that California is doing its own state HIE, state-sponsored HIE. The products have not been fully spec'd out yet. The pricing has not been spec'd out, and one of the challenges with all of what's going on in healthcare reform is the price shock. The revenue shock is so great to many healthcare systems that some are more prepared to take that shock and take the influx of volume in order to take care of that population, and some are less prepared. So we have a definitely community-focused mission here at SCripps, but we need to make sure that we can maintain solvency to maintain mission at this point. And so it's a very challenging problem. We need to solve it. SCripps will solve it. But how exactly we're going to get there, some of it will be what we referred to earlier, which is bending our internal cost curve and diminishing variation as a major, major component of eliminating waste, really, what it comes down to.
Creating more efficiency, better triage, and getting the right care to the right patient at the right time, that kind of philosophy.
Healthcare is just fraught with inefficiency and waste. If you're a disciple of lean management or anything like that, like some of the organizations nationwide,
I'm trying to be.
Yeah, I am too, and and we are beginning to look at lean management within SCripps because we really believe there's an awful lot of value in that. No pun intended, but there is. It's diminishing the waste and looking at value, and that's going to be our critical, I think, step to diminish the cost, because we can shift the pricing, but we need to diminish our cost as well to create value.
At least, California's expanding their Medicaid program, and I think providers, clinicians in states where that's not happening, particularly the hospitals, may have a problem because they're going to still have a big influx of big population of uninsured. Well, Kevin, this has been great. Thank you very much. I'm sure under your leadership, SCripps Coastal is going to continue to improve the quality of healthcare for people all around the San Diego area. Appreciate your time. This is Mike Miller. Thank you for watching. On behalf of myself and Kevin Hirsch, be well. Thanks, Kevin.
Thank you.